Hi, morning. So I'm just going to brief you about the different intraoperative imaging techniques that we have today in our surgical armamentarium. So as we know, the demands of our patients, especially in cataract surgery, are constantly increasing. This intraoperative imaging can take our accuracy and precision one step further and give you an edge when performing your cataract surgery. So essentially, what this does is it helps you plan your toric IOLs. It gives you an heads-up display of which axis exactly is required for you to implant your toric IOL. It will give you an marking as to where you have to place your incisions. In case you want to treat the astigmatism by placing your incision in the steep axis, it will tell you where exactly to do it, and also can also give you an overlay of your rexus as well, so you can get a perfectly well centered rexus which is 5 which will overlap the optic edge as well. So this is how it is. There are essentially the two companies which have it right now. One is the Zeiss, other is the Alcon, both of which are comparable in nature. So we have experience with the Zeiss Callisto per se. So how this works is, again, like I said, it gives you the incision position if you wish to treat the astigmatism. Gives you a rexus overlay, so you can center the rexus, and also allows you to align your toric IOLs. So you need the IOL master to integrate the Callisto system. It takes a pictures of the patient's blood vessels and the limbus, and uses this as a reference mark to get the 180 degrees, and allows you to align your toric IOL along the respective axis. So this is a video of the same here. As you can see, before the surgery is beginning, the Callisto machine is turned on. The yellow line will represent the 180 degrees, which has already been captured by the IOL Master 700. The three blue lines are there, which is where you need to align a toric IOLs. You need to align along the central blue line, which is now the 124 degree mark here. As you see here now, the surgery is about to begin. So we'll just fast forward through the steps. This is a routine phaco. So after the nucleus fragmentation and emulsification is done, it's now time for us to implant the IOL. So you implant the IOL into the bag, and then you wait for the Callisto to turn on, and then you can align it along the correct axis. So you just have to align the toric marks along that blue line, the central blue line, which is now the 124 degree axis. So I can see here it's very easy for you to get that alignment done. And this alignment is quite precise. You can be spot on that this is at the 124 degree axis. The other thing it also helps is with the rexus overlay. So as you know, especially when you're planning your toric IOLs, it's very important to have a well-centered rexus at 5 If your rexus is not completely circular or a little decentered, this can lead to IOL tilt, and it can lead to your IOL being misaligned, and your toricity will then be altered, giving rise to suboptimal results. So this is a rexus overlay. The inner circle is about 5 outer circle is 5.5 So you might think to yourself, okay, I'm an experienced surgeon, I don't need this overlay mark, I know how to make a 5 rexus. But believe me, once you try this, it gives you consistent results and gives you a very, very well centered rexus, which will be very helpful in getting your toric IOL stable. And you can be sure that the percentage of the toric IOL from misaligning will be very less. So this is a routine phacoemulsification. I'm going to skip all of that and just go to the implantation per se. So as you see here, again the IOL is being implanted. The yellow line will be representing the 180 degree, and this toric IOL is being implanted at the 131 degree mark. You just have to align it along the three blue lines and ensure the toricity marks it is in the central blue line. So this is here at the end of surgery, and also you have to ensure that you evacuate the visco under the IOL to ensure that the IOL doesn't rotate in the early post-operative period. You just have to align it in the central blue line. That's about all. So at the end of surgery, you hydrate the incision and you can close up. So again, the literature is quite clear about this. I picked up some studies from very well-reputed journals from JCRS mostly. All of these studies tells us that when you compare the manual marking with the the intraoperative imaging has a little lesser chance of having a IOL rotation in the early postoperative period, and you will not have that many IOL rotations. This because this manual marking is prone to human error. One is you do use these ink marks to mark it. The other is it is done via your hand. So there are chances of having a few degrees clockwise and or anti-clockwise of error. This imaging system will greatly reduce those chances. So again, these are four very well-reputed studies from well-reputed journals telling us that intraoperative imaging does give us a significant advantage. Another thing is it also has less deviation in the target-induced astigmatism when compared to the manual marking. So this was done with the Alcon system as well. So like I said, there is no real difference in the outcomes when you use the Alcon or the Zeiss system, all of which are very predictable and give you good results. So in case you are using the 3D system from the Zeiss as well, you can incorporate this into your practice. it is all well compatible with a 3D microscope. The next technology I wanted to speak about is a femtosecond laser. So as you know, this also uses as a type of imaging. It's an OCT based imaging and performs multiple scans of the eye, and all of the dimensions are displayed prior to the initiation of the laser. You can go ahead and do your LRIs, you can do your incisions, your rexes, and your nuclear fragmentation patterns as well. All of which can be modified according to the surgeon's preference. So this is just a video of the scanning. You see, you have planned an LRI for this patient now, and this is a scan done by the OCT. Scans the cornea, the anterior capsule, the posterior capsule, and here's the rexus being done, and here's a nuclear fragmentation. Typically, I would not advise you to use the incisions because the incisions made by the femtosecond laser are currently too corneal. They're not very limble, so it's a little inconvenient. So we don't really use the corneal incisions per se. Rest of it is quite routine. As you see here, the amount of power used is quite negligible, and one can easily fragment the nucleus and emulsify it with almost no effort at all. So this is the advantage of the femto. I'm just going to skip ahead now because this is quite a routine surgery. So again, the literature is quite clear about this. We know that the LRIs performed by the femtosecond laser are more predictable than manual LRIs, and they do stay for the treatment of the LRIs from the femtosecond laser do stay for a longer period of time in comparison to the manual LRIs as well. This is the Alcon Virion system, similar to the Zeiss. So it does pretty much the same thing as the Zeiss Callisto. The other thing I want to talk about is intraoperative OCT. So unfortunately, I personally do not have experience with the intraop OCT, but if you do have this technology, this is where it can help you. In case you're implanting an ICL, you can have a real-time imaging of what is happening. You can even measure the vault intraoperatively. Intraoperative OCT has found tremendous use in retinal surgeries. So this is where the most of the benefit will be gained by VR surgeons. So that you can help them guide decisions when they're performing surgeries for PDR, RD, or even membrane peeling. This is a pioneer study which says that when surgeons use the intraoperative OCT for the ERM peeling, there was an improvement in visual acuity, reduction in macular thickness, and lower recurrence rate because they're able to do it much more meticulously at better accuracy. Again, this is another one which said intraoperative OCT for VR surgeons. It confirmed and the feasibility of it and ensured that the patients had a better outcome. So again, this is for VR surgeons. And also, if you are a cornea surgeon, this also helps you to do penetrating keratoplasties. You can have a better confirmation that the graft and host junction are well adhered. Lamellar keratoplasties to ensure that the lamella is well attached to the cornea. All can be seen by intraop OCT as well. So I conclude by saying image-guided surgery assists the surgeon to perform precise steps by having an overlay of incision in the cataract, rexus size, and toric alignment as well. Flax technology uses OCT-based imaging to map the structures prior to the lens and the fragmentation. So assess both the technology to determine if the benefit is worth the investment to your practice. That's the end of my presentation. Thank you.